Welcome everyone to CCHI's webinar, Leading a Healthcare Language Access Program in the Midst of a Pandemic. My name is Natalia Mitrova. I'm the Executive Director of CCHI, and I am going to introduce our host, who is then going to introduce the panelists and take over. I want to thank everyone for being with us today during this very difficult time for each one of us, where the new reality that we're discovering is changing daily. And that's why we wanted to hear from managers like you who work on the front lines about their life, about their daily challenges. And without further ado, let me introduce our host, Jorge Ungo, CCHI Commissioner. And of course, many of you know Jorge from many other roles and organizations that he's been part of. I know he started his career more than a decade ago. I'm not going to go too far. He was active with several national organizations, including NAJIT, National Association of Judicial Interpreters and Translators, TAHIT, which is Texas Association of Healthcare Interpreters and Translators, and of course NCIHC, National Council for Interpreters in Healthcare. He's also been working with several language vendors and Pacific interpreters, if any of you are here present today who remember that far, but also with Language Line Solutions. He's been an inspiration for many of us, and we're really grateful at CCHI to have him as our commissioner. So Jorge, the floor is yours.
Thank you so much, Natalia. On March 11, 2020, the World Health Organization declared COVID-19 a global pandemic. As stay-at-home orders went into effect and public gatherings were essentially banned, the language services industry started to see the effects of the pandemic as international conferences announced cancellations and travel seemingly came to a halt. Around the same time, we started reading news of the healthcare systems in other parts of the world being overrun and staff and providers being overwhelmed by the rapid spread of the coronavirus. Shortages of ventilators and PPE dominated the headlines and took our collective breath away as we prepared for the worst. It was inevitable. Coronavirus would impact the U.S. healthcare system in a significant way, and in turn, the healthcare interpreters that take part in the delivery of culturally competent care for the millions of limited English proficient, deaf and hard of hearing patients around the nation. Across the country, hospital systems went into crisis planning and response mode as the number of cases began to rise and spread. We all learned new vocabulary as social distancing measures were put into place, and Facebook posts urged our friends and neighbors to help flatten the curve. However, we also learned that while COVID-19 does not necessarily discriminate, it does disproportionately impact communities of color. News stories began to hit the web regarding shortages of multilingual resources and the omission of interpreters from important news conferences. Most chilling was an article published by ProPublica on March 31st, which illustrated gaps within language access programs in certain New York City hospitals, gaps that were severely affecting the quality of care received by patients of limited English proficiency. As the late Fred Rogers, one of my childhood heroes, taught us, during scary times, we must always look for the helpers. The helpers inspire and bring us comfort. Today, we are joined by three helpers, three language access leaders from health systems in different parts of the country. Today, we will hear their stories and learn from their experiences. First, I'd like to introduce my fellow CCHI Commissioner and the Language Services Program Manager at Nationwide Children's Hospital in Columbus, Ohio, Valerie Huang. Prior to her work at Nationwide Children's, Valerie served as the Program Director for Asian American Community Services and was the 2017 recipient of the Community Action Award from the Ohio Commission of Minority Health. Thank you for joining us, Valerie. Next on our panel, we have the Director of Language Services from Parkland Health in Dallas, Texas, Meredith Stegall. With a background in Lean Six Sigma and a self-proclaimed data geek, Meredith has played a vital role in the growth of Parkland's language access program from 330,000 medical interpretations per year to over 1.2 million, making it one of the largest language access programs in the country. As a side note, I'd like to congratulate Meredith on recently completing her Master's of Health Leadership and Management at UT Dallas. We're grateful to have you with us today, Meredith. And our third panelist today is the Interpreter Services Supervisor for Video Medical Interpreting at Stanford Healthcare, Angélica Villagrán de Gonzales. For over 13 years, Angélica has been serving the LEP population at Stanford Health in the Bay Area of California in a variety of roles. Her most recent, leading the expansion of video remote interpreting throughout the Stanford system. In 2011, the California Healthcare Interpreting Association honored Angélica with the Interpreter of the Year Award. It's an honor to have you here with us today, Angélica.
Thank you. Thank you for having me. I appreciate it.
Great. So I'd like to go ahead and start with you, Angélica. Can you tell us a little bit more about your organization and your patient population?
Stanford Healthcare is a leading academic medical center, and we have a level 1 trauma center with 613 beds, and we offer an array of languages and modalities. Thank you.
Great. Can you tell us a little bit more about your language access program? How many staff interpreters do you have? What languages?
Of course. We have a total of 57 interpreters and translators on staff. They all cover both roles. We have 31 clinic locations that spread across the Bay Area, and like I mentioned, 613 licensed beds. We offer 15 languages on staff, and we offer 200 languages through vendors in different modalities. With our staff, we offer all three modalities, in-person, VRI, and OPI. And with vendors, we only offer OPI and in-person. We don't offer VRI through vendors. So our VRI system is internal.
Excellent. Wonderful. Meredith, if I can switch over to you, can you tell us some more about Parkland Health and your language access program?
So Parkland Health and Hospital System is the primary training institution of UT Southwestern. We are a level 1 trauma center, one of the top NICUs, one of the top burn units in the area, and we also feature 33 community-oriented primary care clinics, along with all the ancillary and specialty clinics. We run approximately 900 beds. With the COVID build-outs, we go up and down depending on need and demand, so don't hold me to a specific number over 900, but you get me. And then we are an organization. Language Services itself is a 160-person organization right now. We offer in-person interpretation and a video call center that is staffed by our staff in English or in Spanish. And then through vendors, we offer approximately another 40 languages by video and up to 200 by OPI.
Excellent, excellent. And so your videos program, how long have you had that in place?
Our video program, as we know it now, has been in its form for about 2 years. We took on a big effort to insource the majority of Spanish language work from our vendors because we determined that we could do it better, smarter, faster, less expensively, and provide really good benefits to Dallas County employees. Excellent.
And I'm going to go back to this later, but I think it's important to note that both of you had these remote interpreting, these in-house remote interpreting programs prior to COVID-19. And we'll get back to that in a little bit. If I can switch over to Valerie. Valerie, I don't think your camera's working today, which is fine, but Valerie, can you tell us a little bit more about Nationwide Children's?
Yes, thank you for having me. We are a non-for-profit freestanding organization with over 600 beds, 600 licensed bed pediatric care facility. We are also an international destination pediatric care center, and as well as we've been considered as an anchor pediatric institution in a diverse community. So we actually has the privilege to caring patients whose family speak range of different languages. Recently in March, we celebrate the grand opening of behavioral health pavilions, which is a 9-story facilities dedicated to behavioral health. Basically, we have acute behavioral health services with intensive outpatient program. Before COVID, our hospital has annually 1.4 million patient visits, and then among all our patient population, 13% of our patient population, their preferred language is not English. So that's a little bit overview of our organizations.
Thank you, Valerie. And Valerie, your language program, do you have staff interpreters? I'm assuming you also work with vendors to supplement that?
Correct. So we have a team of staff who manage scheduling. We cover 24/7 scheduling, dispatching operations. We are able to have on-site Spanish coverage 24/7, even before and after COVID. We provide over 110 languages in 2019. And then if I remember it right, annually, again, this is before COVID, our average monthly section is 12,000. So we are very busy. Before COVID, we had our staff interpreter work on mix of on-site and OPI. So we have a phone remote call centers before COVID. And how it works is majority of staff who have pre-scheduled appointments, and during their downtime, they return to office and then log into the phone and take over from the phone calls. So it's they are primary mode still on site, which is in favor by most of our providers, and that's why our scheduling model was like that. Yeah. So. Got it.
Excellent, excellent. So again, prior to COVID, you already had this OPI infrastructure in place to be able to, I guess, from a productivity standpoint, right? To be able to keep your interpreters as busy as possible and to provide more care to your providers with your own staff interpreters.
Exactly. Yes.
Okay. And then one last question for all three of you, and Angélica, since you kind of went first, I'll start with you. As far as bilingual providers, so, you know, a lot of the news stories that we were seeing were talking about, you know, challenges with language services and needing to have more bilingual providers. Does Stanford have a program for leveraging bilingual staff and testing or validating their language skills?
Yes, we do. That's an excellent question. We're actually working very hard to implement this program. We've had it in place for a number of years now, but we really are making a lot of changes to ensure that all bilingual doctors get tested. We have the CCLA test that we offer through the QBS program, Qualified Bilingual Staff Program, and we're offering incentives and we're making it very streamlined and very easy for providers to register and take the test. They can take it from home and they can take it in 30 minutes and we get the results the next day. So we have really streamlined our processes to make sure it's as easy as possible for them to have access to this test. And it's a very reliable and well thought of process and test.
Thank you, Angélica. And Meredith, how about at Parkland? How are you working with bilingual providers there?
So Parkland has pretty much always had a qualified bilingual staff program. When we implemented our TCU, our tactical care unit, that was specifically aligned to COVID positive patients, we did our best to make sure that we could also align nurses who were qualified bilingual staff and physicians to that unit in order to minimize the need for potential emergent need to gown up in PPE interpreting, as well as once we figured out we're not going to let in-person interpreters into that area, an option outside of the video interpreting that otherwise was available. Because, you know, when you got patients that are coming off vents, sometimes that video or that OPI is just not going to work. And so we basically, for that unit, suspended some policies and said, in this particular situation, you may interpret within a limited scope in order to help these patients.
Yeah, excellent. And Valerie, at Nationwide Children's, do you also have a bilingual staff program?
We are in the process of rolling out QBS program. The reason we were putting it on hold last year for several reasons, and of course one is budget, because we have to test our bilingual providers. So that was putting on hold. But we found the most major reason that we have to put it on hold is that we want to make sure that our provider understand the differences between interpreters, a qualified interpreter, and a qualified bilingual staff interpreter. We have a group of very anxious bilingual providers that they thought that they are going to be an interpreter. So we have to kind of put that project on hold and then do a re-educating about what's the difference between qualified interpreter and qualified bilingual staff. But actually we're ready to roll out this year.
Angélica, did you want to add something?
Yes, Valerie just made a really good point. Our QBS program only enables qualified providers to communicate directly with their patients without the use of an interpreter, but it doesn't enable them to interpret for anybody else.
Sure. Yep. Same at Parkland, Meredith.
Yeah, so I would echo on that, and that's why, you know, we specifically partially suspended the policy for that unit to enable that limited scope. But the other interesting thing that we were lucky to, Parkland really focuses on pushing our interpreters to consider nursing school. And so within our unit that is taking care of this patient base, we actually had 3 former nationally certified interpreters who are now critical care nurses on that unit.
That's amazing. That's awesome. Great. Well, that, I mean, obviously we're talking about 3 really robust programs. You know, it seems that a lot of thought had been put in place ahead of time. I'd say, you know, from my work with healthcare organizations across the South, definitely, I think, you know, a lot of the infrastructure that you already had in place set you apart from where a lot of organizations were, and the steps that they had to take in a very rapid manner once the pandemic started to unfold here in the U.S. So I guess stepping back a little bit and thinking about your organization and kind of where you were on March 11th, which was, as I said in the introduction, when the World Health Organization deemed this a pandemic. I mean, obviously preparations were in place prior to that, right? You probably were already working on initiatives. So just thinking as big picture, your healthcare organization, what were some of the first steps that you all took to sort of prepare your organization for what was coming? Meredith?
So I got a big dose of humility when we started really shockingly fast moving into this. The first thing that I did was I set up 3 times weekly huddles with my staff, and the very first one is, I don't know what I'm doing right now. We don't know what the protocols are going to be, and I need you all to be as flexible and as understanding as possible. My key things in everything that we're going to do over the next, you know, however long this pandemic lasts, are to keep you safe, to keep you financially solvent, and to provide quality care. And I said, we're gonna move through this, and we're gonna change at light speed, and we've just got to be ready to go. So that's pretty much the approach and the humility that we hit it with immediately.
Yeah. Yep. Angélica, what about at Stanford? I think you know, California started to see cases prior to Texas, so you may have had to start taking some of those steps even earlier than Meredith did. What were some of the initial steps there at Stanford?
Our organization implemented multidisciplinary task forces that had different tiers and committees, such as PPE Conservation Committee, the Patient Search Staffing Committee. We did not allow any visitors in units, and now presently we are limiting the number of visitors to one visitor for only specific units. When a person comes into the building, we take their temperature, we give them a mask. All the staff members have to wear masks and observe social distancing, even in offices. So our department in particular reacted very swiftly. We were lucky to have had a very robust VRI program. Our program has been in place since 2009. So a lot of the legwork had already been done. Our interpreters were familiar with VRI, the doctors were too, and we only had to learn new protocols to access the platforms for telemedicine appointments that had no touch solutions that were being implemented by the COVID-19 units. In the outpatient setting, we did most of our encounters through VRI already. So it was only a matter of getting ready for the search in the inpatient setting. We always provided in-person interpretation in the inpatient setting. So now it was a matter of switching gears, and I really have to give a shout out to our IT department because they moved so quickly to deploy iPads that had Zoom in them, and they were very good ways to communicate with patients. We just left the iPad in the room, and that way everybody who needed to communicate with them, whether they needed an interpreter or not, they would do it through a master iPad on the outside of the room, and they would log into the room and they would speak to the patient for whatever they needed. That really limited the number of times the staff went in and out of the rooms, and it limited the amount of PPE that had to be used. And so we had to switch gears a little bit because the way we offered VRI in the past was through one specific application. So we just needed to train our interpreters on how to use Zoom and how to use WebEx, because these were new platforms that were being used in the inpatient setting.
Right, right. And so Valerie, for you, I mean, being in a pediatric specialty setting, I would imagine that the speed and the not apprehension, but just the expectation of having this influx of patients wasn't as severe as it was for Meredith or Angélica's institutions. Can you tell us a little bit about how what was going on at Nationwide Children's there at the very beginning?
Yes, so in response to COVID-19, the hospital encouraged employees to follow any new policy, procedure related to illness, cleaning. We even implement flexible meeting options. Our staff are asked to move all the on-site staff meeting to Skype or the WebEx option fairly early. We also introduced travel restrictions among staff, and that also applied to our external resources as well. And I also remember that our team, my team, that was the very first group that shifting our staff meeting to remote options. I think that's back in early March. So our hospital also introduced visitor restrictions, like Jorge, you mentioned that we're a pediatric section hospital, and then a lot of time you have a lot of visitors. So we only allow for a limited number of personnel in the clinical area fairly early. So for next phases of response was, for me, is really to think how we gonna deliver our service in the midst of pandemic with the new norm of physical distancing. And then of course, like Meredith mentioned earlier, that staff safety, my team safety, it's my priority as well. So the fact that language services is the only few groups that in our hospital has already provided service remotely. So that's the fact that everybody knows. So we actually ship very fast that move majority of our services to remote within 2 days. We wrote out a communication plan, and thanks to our marketing and engineering, we communicate with clinical team about the upcoming changes. We utilize outlets like internet, digital bulletin boards, email blasts. We reach out to all the manager meetings. I was really surprised that the clinical team was very supportive. They are very understanding that they probably are not gonna see interpreter coming on site, but they're very supportive that because with the understanding that to promote physical distancing and preserving PPE, they are really, really happy. And then another thing to share is I was able to build our VRI call center within 1 week. That's with the support for our IT, like Angélica mentions, that we already have infrastructures. We reach out to IT, request a COVID-related project. We already have a call center that only support phone. Can we get some help? So we were able to go live our VRI within 1 week. So that's what's very fortunate for us.
Yeah.
Yes.
Wow. Wow. That's, I mean, the speed at which things were, you know, getting off the ground, and the amount of collaboration between departments, I think, is something that you know, we've seen it in the past, but to see it, you know, happening in so many different directions with so many different departments, I think it's exciting. I mean, given the unfortunate circumstances, but definitely exciting to see how quickly we can all come together to get something like that in place. So I'm hearing a lot of, you know, leveraging technology, but you know, something that I want to point out, and you know, I think something that a lot of the news stories, in my opinion, overlooked, is the fact that even though you were caring for COVID patients, you were still delivering babies. You were still tending to car accidents. There was still a need for you to provide healthcare to the greater community, and in turn, still, you know, in certain instances, provide on-site interpreting services, right? So Meredith, your on-site program continued going, right? Your on-site interpreters still were delivering service in those other instances?
Absolutely. Our on-site program continued business as usual, other than we had the restriction that there would be no direct, except in extreme and emergent situations, we would not be seeing COVID positive patients. So we, to this day, are screening patients in the emergency room. We are in the back of the emergency room. We're in labor and delivery. We are in the ORs. We're in the critical clinics. That didn't stop. So, you know, then it becomes to what Valerie mentioned with the PPE, keeping them safe, making sure that Parkland rolled out mandatory masking very early. And that we were very lucky with that, because between mandatory masking as well as social distancing between patients, it's kept our staff very safe. But, and I'm sure our other groups have found this now, what we are finding is there are new risks to interpreters with this other volume, the car accidents, the babies, because those that aren't showing symptoms are then showing positive tests later on. And so we have to make sure that we implement protocols that say, even if this isn't a suspected case, we're going to treat everyone like it is. And so basically every single one of our interpreters can quote me as saying, how many feet do you stay away? 6 feet. You know, it's, so unless it's an extreme hard of hearing situation, they're not going to cross that 6-foot barrier. I don't know if did I get to the heart of your question? Yeah,
no, for sure. Yeah. I think, you know, there's this perception that everything went remote. And I know that that's, you know, not necessarily the reality of it, right?
No. So, you know, if you think about Parkland, you know, I mentioned that we're the #1 training center for UT Southwestern, but we are the safety net of Dallas. And so when you look at our patient base, you look at extremely low health literacy level, you look at psychiatric issues, you look at all of those things that could potentially preclude a patient from safely using VRI and OPI. And so we would have been remiss to pull everything back. And so, you know, with the focus on safety, we were still able to deliver all modalities.
Yeah. Yeah. So Angélica, I think, and I'll take this question to all three of you actually, but the other piece of this is that yes, we, healthcare continued to support the general population in your communities. There were still, surgeries that had to take place. Again, I mentioned babies that needed to be delivered, but we've also seen in the news the economic impact of COVID-19 on healthcare organizations. Unfortunately, rural hospitals that were on the verge of collapse are now shutting down because they're not doing elective surgeries and outpatient services the way they were before. So Angélica, how has that impacted Stanford?
As far as the interpreter services department is concerned, we actually, our volumes went up in interpreting because we created a phone tree that routed all the calls that were in the past going to vendors, and we linked them with our VRI system. So all those calls are coming through our headsets and we are capturing them. So in the case of interpreter services, our levels are still the same as prior to COVID-19 or higher. So it didn't impact our staffing levels. If anything, we need more staff.
Okay. But how about the organization as a whole? I mean, you did, are you back? Are you restarting elective surgeries, or is that still on hold?
Yes, elective surgery started back the week of May 6th. So
Okay.
we're slowly but surely recovering. Also, we moved a lot of our outpatient appointments to video appointments. So patients have My Health app on their phones, and they are using that to communicate with their doctors. We are working very hard with IT to include interpreters into that modality. So what we are doing now as a workaround is we interpret for them over the phone while they can see the provider on the video. But we're hoping that in a couple of weeks, we will be able to have a 3-way video conversation through that application as well.
Awesome,
Some of
awesome.
the are using Zoom as a workaround. So we are getting the Zoom links and we are interpreting through Zoom. And we are very happy to announce that we're also in the verge of offering simultaneous interpretation through Zoom as well. IT is working very hard to include that also. So we're doing teaching sessions and DBT, CBT groups through Zoom as well with simultaneous interpretation.
Wow, wow. Well, we're going to talk a little bit more about telehealth, but just to wrap up on this topic, the kind of the pause button on elective surgeries and outpatient services, unfortunately for a lot of healthcare organizations, resulted in a reduction in workforce. Meredith, can you talk a little bit about how that, what the impact has been at Parkland, and in particular with your language services program?
Absolutely. So step one, when you lose 50+% of your case volume from outpatient visits to the surgeries, etc., our demand did go down. But what that meant was, like Angélica said, we were able to redeploy more to the video because we had an increase in telehealth appointments, which was driving the volume there. And it also meant that we sent less to our vendors. The other thing that we've done to preserve interpreters and jobs in this period of time is the Dallas County Health and Human Services had a spike in Spanish-speaking COVID-positive cases while they lacked Spanish-speaking contact tracers. And so as of Friday, we are now the predominant Spanish language contact tracer for Dallas County Health and Human Services. And so that has also helped us maintain our productivity and value to the broader organization. And so the likelihood that anyone will come and try and touch our FTE and mandate PTO and things like that is very small at this point because we've taken on that additional work.
Wow, that's incredible. Angélica, have you seen, are you seeing, I mean, it sounds like your volumes are up, so I can assume that the answer is no, reduction in force, but have you seen it in general at Stanford?
No, we have been working very hard to not lay off anybody. So one solution that the institution has come up with is asking us to take 1 day of PTO per week from now until July 4th. And that has really, really helped our budgets, you know, and then we don't have to furlough anybody.
Yep.
And everybody's doing it, from the CEO to, you know, everybody across the institution.
Right. Well, and I would think that that has also some vicarious benefit in the fact that, you know, your mental health is impacted positively. I mean, I can, you know, I haven't had the opportunity or the need or the ability to step into a hospital, but I imagine, or a health system, but I imagine that right now tensions are high. Things are changing constantly. So that extra day off is probably a welcome reprieve.
I can tell you it's been very beneficial, at least in my case. We moved most of our interpreters to work from home, so they really appreciate this 1 day off to, or, you know, some of them are taking it in 1 week off and then they don't take any time off. So depending, the institution was very generous in letting us decide what we wanted to do and how we wanted to do it. So we are just very lucky, and we welcome this nice little break because COVID-19 came so surprisingly, and we had to work like around the clock for weeks. So now this is a welcome little break.
Yeah, no, I can imagine. So one last question, and then I really want to segue into the telehealth discussion. But, you know, as I mentioned in the introduction, obviously we are now seeing the disproportionate impact that this is having on our communities of color, on our, you know, on communities that are in different socioeconomic places with access, different levels of access to information. And again, the news has, you know, we've seen the news reports of there being gaps in the amount of multilingual resources and press conferences, and, you know, a lot of information was online, and some people don't have access to the internet. So what has been asked of you? What has been asked of your department to help address these gaps in our public health system? Meredith, Parkland is the county hospital for Dallas County. What role are you playing in educating the general public?
So it's been interesting. Parkland, you know, we are a truly bilingual hospital. There is no assumption that anyone speaks English when they walk in the door. And so with that, from a marketing perspective, we have hit heavy and hit hard from a marketing perspective, and working with, Parkland has what's called the Parkland Center for Clinical Innovation. And they have done text campaigns that are in multiple languages that are directed specifically at these communities of color, at the zip codes that are most likely to be impacted. And so we've been, you know, tangentially involved in all of that, as well as, hey, health department's got an issue with contact tracing now that we've got this explosion. And so we were able to step in and fill that need and gap.
Yeah. Angélica, what about you? Given the breadth of languages that that you have there at Stanford, has that been leveraged in the community at large to help do outreach to these communities?
We have had a very high volume of translations that have been requested of us in all these languages. So we're so lucky to have wonderful translators in place, and we have a very robust translation program that is internal. We hardly resource any we hardly outsource any translations, but our translations team, also a big shout out to them. They've been so hard at work with all the documents that we produce, and then they change a little bit, because you know how with COVID-19 the information kept changing like every 10 minutes.
Yes.
So the poor translations team was just so hard at work, like, okay, another change, okay, we'll do it. Another one, okay, and then that had to be multiplied by all these languages. So kudos to them.
Yeah, no, absolutely. Do we wear a mask or do we not wear a mask? I don't remember.
Yeah, I have to echo what Angélica is saying. You know, those 3 in the afternoon on a Saturday or Sunday requests where you've got to call and beg people to log in. I'm sure that that's what you all had to do as well.
Yeah, absolutely. And Valerie, in Ohio, what has the outreach there been like to the community?
So in Ohio, we have a pretty robust public health program in a state level, in a county level as well. So, I mean, as the perspective from the hospital, we don't want to reinvent the wheel, rather than more collaborations, in a sense that just like for example, our hospital website, we try to update with all the COVID-related informations, not so much about what we translated, because we have most of them already translated by the state. So we kind of keep linking those to them. And then, but I want to mention though, our primary care centers has been viewed as a community center. The reason is that we build that primary care center in certain area for some reason. It's most of the primary care center are built in underserved communities. So our primary care center remain open, and our staff interpreters still there on site, providing on-site interpreting. So they actually wear both hats as an interpreter as well as the navigators. So as long as patient walk in or call, our interpreter was able to help them to get all the necessary information related to COVID. So I think that's what I think we've been very successfully to collaborate with public health officials and to continue to serve our communities.
That's fantastic. So I don't think that I have uttered the word telehealth as much as I have over the last 45 days. It seems like every conversation that I have, even on a personal level, the word telehealth comes up in some way. And it's funny because, you know, at conferences in the past, and, you know, I've talked to folks in healthcare, you know, about what are you doing about telehealth, or how does your language services program work with telehealth? And there wasn't really a lot going on at the time, right? I'm talking last year, the year before. Now, Meredith, I know you and I have had a conversation in the past year about telehealth, so I know it's something that you had already up and running. So was the transition to telehealth for Parkland, was that just kind of just a matter of disseminating and letting people know that it was already in place?
So from a language services perspective, you're 100% right. We had already been working through virtual care platforms. We don't use the term telehealth, we use virtual care, okay, because it's not telephone based, and we wanted to get away from that nomenclature. But it's been interesting to watch, because we had one predominant platform that they were actually transitioning away from as we entered into this. And so we ended up on multiple platforms in this process, some that worked well and others that didn't. Within our COVID care unit, or TCU, they ended up with these units that didn't work with our video call center. And so we had to develop these alternative processes that still I'm not happy with. But it's been interesting to have to flex on a dime related to these platforms, and you know, just the convergence of we're transitioning away from one while this is also happening. So that's been a lot of fun. But again, interpreting for those visits is something that our staff were already used to.
Yep. And I want to talk a little bit about the training of that when we get to the next section of this. But Valerie, what about you? Where were you? Where was Nationwide Children's kind of in that continuum of implementation of some sort of virtual patient care technology?
Yes, so telehealth was pretty new to our groups. I know that telehealth concept solution was introduced on and off, and then basically since we are a leading pediatric hospital in the area, I think it's more like to rely on the resource wasn't utilized as a physician-to-physician consult. So with that, the transition to telehealth, I personally witnessed from language service perspective, it's just that there's a lot of technology challenging throughout the process. There's again similar to Meredith's situation, as our telehealth solution, there were so many different platforms, and a lot of provider was very confused the whole process. And then also in our organizations, we roll out by groups. It's not roll out the whole entire team. So as you know, if the go live is transitional, phase 1 and phase 2, by the time you're ready for phase 2, something already changed. So we actually prioritize the group who relies on weekly sessions. For example, therapists, behavioral therapists, speech therapists. Those are definitely impacting patients' well-being if their services stop. So those are the first group that we are seeing that first 2 transitions. The challenge is to how to engage interpreter within these telehealth sections. And I found personally, again, working with this group, I think the biggest challenge is a lot of telehealth project team, they are not very familiar with interpreter, how language services workflow. So at the time that when they try to build the algorithm and workflow, in the very beginning, how to engage interpreter was not actually included in the whole process. So we have to retweak all the process and a lot of workarounds. There's so many different ways to engage interpreter. But I mean, we are basically learning by doing it.
Yeah. I think many organizations that I speak to are in that same place. Angélica, I think you mentioned that telehealth. You had already started doing telehealth prior, or some sort of visual or virtual patient care prior to COVID-19. Can you elaborate a little bit on that? And did you face the same challenges with multiple platforms and technology issues?
Yes, the system that we had was internal. We had a VRI system that was internal, where we have a call center where all the interpreters are, and then we interpret for doctors and patients in the room. So now that patients are not coming into clinics, we had to transition to a different platform so that the patient can access us on video. That was the challenge per se, because our interpreters, like I said, have been used to interpreting on video since 2009, and the doctors are used to having interpreters on video. So the only challenge was just switching to a different platform. This platform, like I said, doesn't integrate a third party. So we had been doing workarounds. One of the workarounds was using the phone, but now the workaround is using Zoom, while we continue to work very closely with IT so that this can be integrated and then everything lives in one place. Some of the clinics are using WebEx. Working from home has also been a change for the interpreters. They were used to going to the call center. Now we have them, most of them working from home just so that we can observe social distancing. The ones that prefer to go to the office are observing social distancing in the office and wearing masks. So our challenge was just mobilizing IT very quickly to provide laptops for people to work from home. We created a communications team related to COVID only, because like I said, the information was changing so rapidly that we nominated 2 of our wonderful interpreters who are very eloquent and very good with language in general, you know, and they wrote a lot of policies based on what we kept telling them, you know, and the information that kept changing so rapidly, to keep everybody in the loop so that all the interpreters felt safe, that there was a place to go to get all the information they needed, like, you know, how to log into with the Ethernet cable instead of the Wi-Fi, how to manage a Zoom session where the patient can't hear you, how to do this and that. So we did a lot of quick guides for them to have a reference to access. And
that's excellent.
It worked great, and kudos to this team as well, Johanna.
Yeah. Johanna Parker, that's awesome.
Yes.
Shout out to Johanna.
Yes.
So, and this is an awesome segue into the next section, but, you know, I just want to point out, I think for me, what has resonated with what each of you has said is how incredibly important it is for you to have a very close working relationship with either your technology team, your IT team, your, you know, virtual care team, you know, whatever that team is. And it's something that I've experienced personally, professionally, working with my customers, is that, you know, a lot of times those teams are making decisions and not really, they're not aware, or they don't really, you know, think about it. It's not really their job to think about the interpreter part of it, right? And how are we going to get the interpreter into that room? And then that's always like the last piece of the puzzle, and the hardest piece of the puzzle to try to get it to work. So I think having that strong relationship with that team, and then really being in all of those conversations with them, so that you can always be the voice for the language services program. And I think too, also being well versed in the jargon of telehealth, right? And how the technology works, because you're going to be a part of that, and you really have to almost be an expert in that of yourselves. So this segues really interestingly into kind of how, you know, you all have each been managing your teams, working with, you know, your interpreters, you know, apart from managing these services for a large healthcare organization, you also all have large teams to manage. And so obviously all three of you who were already doing remote interpreter, all three of you were managing a program that was a blended approach of on-site as well as remote interpreting for your interpreters. Meredith, I know you've got a pretty amazing program, a training program there at Parkland. Can you tell us a little bit about how your team has been training your interpreters, and what do you focus on in terms of the differences between interpreting on-site versus a remote interpreting session?
So when it comes to training, 100% of our interpreters, even if they're going to work in our video contact center, are trained as in-person interpreters. And we do that because we want them to understand the perspective of both the patient and the provider that's in the room as they interpret. And so they can take that mindset back to the call center once they go. They're looking for the same visual cueing, the same ability to sidebar if something is going awry, because I think I mentioned earlier, we have known health literacy issues amongst our populations. And so once they get to the call center, then we start focusing on techniques of, okay, now that you are not there physically in the room, what are the nuances of how you would handle this encounter? And so that's kind of the primary differentiation with that. But again, 100% of our interpreters are trained for both modalities and both sets of.
Yeah, and I like that. I like that approach of, you know, the more, you know, for lack of a better word, the more intrusive, you know, modality, which is going to be on-site, where the interpreter is really in the room, training them with that first, and then kind of stepping back into the remote part where, you know, you have a little less access to information because you're not actually in the room, and you know, your other senses start to kind of improve and sort of take over, and you have to really get more creative in how you manage the session. How do you get someone to pause when you can't physically say, please pause? So I can imagine that's challenging. Angélica, what about on your end? What training specific to video and OPI do you provide interpreters?
When we onboard interpreters, we provide a 2-week onboarding process, and that includes all modalities. They do shadowing, we shadow them, and then they do solo interpreting in all modalities. And when they are observing or shadowing our interpreters on site, if it's through video, they wear the same headset. We have a splitter for the headset, so each person wears their headset, and the person in training just listens in. Their audio is muted, or their microphone is muted, and they listen in all the sessions, obviously with the permission of the provider and the patient. And we do the same thing with in-person. There are shadow basically in the room. We haven't hired anybody after COVID-19 hit yet, but we are envisioning following the same processes, just online instead, you know, having the same person in the Zoom room or the WebEx room whenever they're shadowing us. But we haven't had to do any really different training so far because our interpreters, like I said, have been very familiar with VRI interpretation.
And that's interesting. I think that adds a whole new element of quality assurance, you know, that you all can implement. I know a lot of the vendors are able to listen in on calls and, you know, provide feedback to the interpreters, and that's their method of QA. But I think for on-site interpreters, unless you have somebody going in the room with them, which, you know, some of the rooms can be kind of small, you haven't really had that opportunity. So now with telehealth, now you have that new opportunity. So that's interesting. Valerie, for you, you had to kind of transition to VRI for your interpreters really quickly. What did you all have to do in terms of training? Was there anything different that you needed to train them on other than, you know, how to use the new program or how to use the system?
Yes. Luckily, we already have OPI training in place. So staff are able to, they already familiar how to do the introductions, and then how to handle some certain situation, to intervene and to ask for clarification, because after all, it's not visual cue. So shifting from OPI to VRI, I'm hearing a lot of feedback from our staff. Oh my, it's much better than OPI. It's much easier to handle because at least now they have a visual cue. But in addition, though, we do provide more training how to empower our staff to intervene the situation. One of the example is we all know, many of you know that our provider usually just have an iPad or their video device in one of the corners. So if it's our interpreter interpreting teaching section, they need some visual support. So we have to kind of redo our training to remind our staff interpreter that you may need to ask for clarification as provider to reposition the iPads, so that will allow you to have more effective communication. So that's very important. I also find personally that we actually I am a big fan of staff engagement. So with this whole new way of doing their work, we have every other day we have a team huddle meeting every morning, beginning of the shift. That has been helping tremendously. They were able to ask questions, and then my approach has been we want them to own the process. So I have our staff to suggest maybe what's the best process to handle this situation, and then we keep document it and make it a living document and continue to provide support. So I found that personally it's very helpful.
That's great. Yeah, that's awesome. So I imagine that, again, we talked a little bit about the tension, the rapid change within the healthcare organization and processes changing and directives changing. And just, it's got to be a heightened sense of anxiety just walking down the hallway or going to grab something to eat. What recommendations do you have for helping your staff interpreters cope with their own mental health through this? What recommendations do you have for self-care for them as they're going through this challenging time? Angélica?
We are following the same recommendations that the county has given us, just a lot of hand washing, wearing your mask. We are actually cleaning, for the people that are on site, they clean their high touch areas and their cubicles 4 times a day. So we are going through a lot of disinfectant at the moment and a lot of hand gel, but we're happy that we have it. You know, we're very lucky that our institution has plenty of resources for us to stay safe. And this is true for everybody in the organization. So we know that the areas that we go to are safe to go to.
Mm-hmm. That's excellent. Meredith, what about you? How is your staff coping from a mental health standpoint and from a stress level standpoint?
So I know you can imagine with the sheer volumes that our hospital has had, it's definitely been an issue. From a leadership perspective, what we try to do is meet and talk and ask questions and allow questions and concerns to be expressed until, you know, we felt like maybe is there anything else that we could possibly attempt to address? But the other thing is Parkland offers an employee assistance program that gives access to mental health professionals via a video environment. Additionally, we have a peer support program called Sparks that we're involved in, and anytime, night or day, they can engage peer support to just talk about what they encountered, their fears, and then, you know, above and beyond that, if you just need to step away, that's what we need to do. Because I can't take your fears away, but I can try and give you a safe environment to feel whatever it is that you're going through and to be able to step away. So a lot of, we've eased up on some of our productivity requirements to enable that. You know, if somebody is just having a day, then it's something that we get. We've got humans, we've got families impacted, etc. And so we just have to remember that our interpreters are whole people. So that's been our attempt at approach of mental health and well-being.
That's amazing. Valerie, so I was on Facebook, I think it was just last night, and in one of the chat groups, interpreter chat groups, there was this whole conversation about OPI interpreting and how challenging it is to hear the provider when they're masked, when they have a face shield on, when you know, they're significantly far away from whatever equipment they're using to access the interpreter. So Valerie, for your team, has that been an issue, and what techniques have you used to try and improve that sound quality for them?
Mm-hmm. So for on-site interpreter, they've been used to having mask on, especially when the situation that they see the sign of contact precaution sign is on in the exam room. So I would say that they've been trying to coping for interpreting over the mask for many years. So I haven't heard any concern from our on-site interpreter. For our staff, the group of staff who are providing OPI and VRI. So although we are ready to provide service remote, we are not remote ready for our staff to work from home. So all our staff are working in the office. So my wonderful strategy is to decentralize our office. We make sure that everyone in our office has, so we basically move half of my team to another location. So that allows them to not need to wear the mask when they are doing their OPI and BRI. So that's kind of a workaround for our team. Yeah.
Okay. Okay. Meredith, what about you? I mean, have your interpreters reported that they're having a hard time hearing the providers?
So, you know, that we've always had some of those issues. You know, we've got providers who attempt to make these calls on their cell phones. They don't stand close enough. This is just nothing new for us, honestly. So our interpreters are just really used to saying, hey, you know, I need you to enunciate. Can you speak? Can you get closer? You know, all of those things are just very normal. And I hope that everyone realizes I'm telling you that a Parkland interpreter basically deserves hazard pay for what they have to go through on a daily basis, just doing video and voice work. It's suboptimal conditions, and they do an amazing job day in and day out. Mask, no mask, physician too far away, various accents at play. It's just part of what they flex to. Yeah,
no, that's. I mean, I would say that's probably the benefit that they have of working for a safety net hospital and working in such a diverse city as Dallas is being exposed to all of those things. So now today, you know, working with a provider that's wrapped up in PPE isn't really it's not the new normal. It was the normal for them before. So I want to segue quickly because we're running out of time, and I'm just like so into this conversation right now. So a question that I don't want to forget to ask is around American Sign Language. So all of us serve a deaf and hard of hearing population. We know the challenges with serving that population when we're not in a pandemic. And making sure that providers are making the right decisions to pick the right modalities. But now you don't have as much flexibility, right? Angélica, what have you seen at Stanford around delivering American Sign Language interpreting services? Has anything changed?
At Stanford, we're very lucky that we have 2 staff interpreters that do American Sign Language interpreting. We haven't changed much. We usually offer sign language interpreting in person. Now we are switching more to video because they are working from home, but when it's needed, they do come in person. And we are lucky that in the emergency room, all of our rooms have a glass door. So they are able to actually interpret through the glass, and they don't even have to come into the room. So it's been very beneficial. It hasn't been too challenging. One challenge we had was that sometimes the camera only picks up the person who is speaking, and that's a bigger picture you get. And then in the small little picture, there was a deaf person signing because they weren't speaking. So that was a challenge, and luckily our interpreter was in the office interpreting through video, so all she did was switch to in-person, and like I said, she interpreted through the glass and it was fine.
Interesting. Valerie, have you run into any issues with ASL at Nationwide?
We, again, like I mentioned earlier, we share majority of our service to remote, and then luckily I haven't heard any complaint about family. But for the telehealth, we found that there's some challenge of technology challenge of that our provider were not able to call out from the Zoom to an interpreter. So our workaround was our scheduler actually joined the Zoom first, and then obtain the meeting link, and then connect our ASL interpreter to the meeting room. So we want to make sure that, of course, we all know that we cannot use phone interpreting to support our ASL population. So we were able to kind of work around, use meeting link, and then engage our local interpreter resources to support the telehealth through video platforms.
Got it. Great. All right. Well, we're getting right to the end here. I want to ask Meredith, what do you foresee changing in the delivery of care to this population, but just in general, what changes do you see coming in the future for healthcare?
So, specific to the Parkland population, I think that this situation has proven that even in underserved communities, virtual care can work. And I feel like we have now empowered an entire community through this, because with virtual care, you can get around the barriers of transportation. You can get around my husband doesn't let me go without my set, without a chaperone, etc. And so I think that this has really catapulted a care delivery method that previously had not been considered as a prime mode for indigent populations.
Yeah. Valerie, what about you? Do you foresee telehealth and video interpreting becoming part of the new normal for you at Nationwide?
Exactly. I was happy to hear Meredith mention that, because I had just had conversation with our telehealth project teams. I was introduced that the whole concept of our LEP population, how they have high no-show rate, it's because the lack of transportation. So with the telehealth platform, we were anticipating this will stay. Of course, it's not going to be dominated on-site visit, but this will be a very good supplement for care for the community. But for interpreter language service perspective, that how we're gonna continue to work with technology, work around, and make sure that the streamlined process is in place to make sure that the service can be delivered more streamlined, so to speak.
Yep. Angélica, again, this has been an extension of a program that you've already had in place for years. Do you feel pressure from your organization to grow it even more now that they can see how remote interpreting can really be beneficial?
I think it will continue to grow regardless, because we continue to offer services to more and more locations now. So I just think this is here to stay. It has grown through the years exponentially, and it will continue to do so. And I'm happy that we are now able to reach remote locations that we weren't able to reach in the past through VRI. So I'm really grateful for the team we have. I know Meredith has a wonderful team, but my team is the best in the nation. I love my interpreters. They're wonderful.
That's awesome. Well, one last question, and then we're going to wrap this up. How do you think this is going to impact interpreter certification, the demand for national interpreter certification? You know, you may have heard Natalia mention that we are now doing online testing of our CoreCHI. So, you know, we're hoping that that's going to make it available to more people. But do you see that need for having nationally certified interpreters growing? What do you think the impact would be, Meredith?
So I'm going to be completely honest as a leader. Amongst all the things that I really need to worry about right now, national certification is not at the top of my list. I have a predominantly nationally certified body. We offer to pay for it, etc. But what I really need everyone focused on right now is taking care of their mental health, taking care of their family, and their general well-being. And so it's not a stressor that I'm going to reinforce right now and probably for another 3 to 5 months. And even then I will evaluate it. It's something that we value, but again, right now I have to value my staff and their mental health more than that certification.
Yeah, Yeah, no, absolutely. I echo that. Angélica, I saw you nodding your head. I'm sure you echo that sentiment as well. And Valerie, for you, and any closing thoughts?
So in terms of certification, I think I'm going to have to continue the practice. All of our staff interpreters are required to be certified or at least obtain the certification within 6 months of hire. So I don't foresee any immediate challenging now because most of the institutions are on hiring freeze right now. So I don't have to worry about that at this moment. But deep in my mind that I will continue. I still think that it's very important to maintain this basic qualification for my team. So that will be no change.
Absolutely. Well, I want to thank all three of you for spending this time with us today. This has been incredibly eye-opening, enlightening, and please pass along our gratitude to your interpreters for the work that they're doing. They are healthcare heroes, and they are providing a vital service to our communities that you know we will be forever indebted to them and to everybody at your healthcare organizations. And again, thank you all three of you for joining us today.
Thank you.
Thank you.
Thank you for the opportunity.
And I also want to thank all the four of you and Jorge for leading this wonderful conversation. I know we've had some more questions, but we're out of time, so we'll try to address them offline. I want to say that, yes, each one of your organization has the most tremendous team, but also I know that I heard saw some comments on from our attendees that their teams are the best. So in general, I think we're all very blessed to have a wonderful profession where we care for each other and we share these things. And you helped, I think, today, many of us to keep that hope and to be engaged. I also want to say that on CCHI's side, we also think about candidates who are trying to start the certification process right now and make their lives easier, but also for our certified interpreters. And one of the initiatives that will be announced very soon after this webinar, most likely tomorrow, via email, but I want you today on the webinar to hear it first. The commissioners want to support our certified interpreters, and we introduced a 20% reduction in renewal fee, which is retroactive to March 1st. So those interpreters whose certification are coming for renewal, we do want them to focus on their lives, and we want to take off some financial burden that a certification renewal may bring. So we're trying to find our ways to make everybody's lives easier and to connect everyone. So thank you, everyone.